So what we would like to do is go ahead and begin with introductions. First, we'll start with the folks in the room, and then I know there are 2 people logged in for the webinar, one of which doesn't have their audio enabled, and that's you, Bev Collins. We know you're there, but you have to sign in with your PIN if you want to enable your audio. Okay, and then we also have Dan Cochran online. Hi, Dan.
Good morning.
Okay, great. So this is Diane Feeney from the HSCRC.
Allison Schuster, HSCRC.
Good morning. Tom Valek, Discern Health, consultant to HSCRC staff.
Elsa Hiley, HSCRC. Tracy Laval from the Maryland Hospital Association.
Linda Costa from the University of Maryland School of Nursing.
Fazzi Savi from Kaiser Permanente.
Justin Dival, Mercy Health Services.
Dan Nguyen, Care First.
Trisha Roddy, Medicaid.
Great. So welcome to
Teresa Lee, NHCC.
I'm so sorry, Teresa.
Okay.
I just take you for granted. That's all it is. And we know that our colleague Shule will be, I tried to combine those 2 words together, will be here momentarily. So she told us to get started without her. So what we'd like to do first is just briefly walk through today's agenda, and then what I'll do is go through the work plan that's in the packet. We'll do it at a high level, just kind of walk through what our next few months is going to look like in terms of the work group process, and then just point to the fact that the current, as we know it, most up-to-date roster of the work group membership is, as far as we know, in terms of folks who have indicated their willingness to continue or to be added to the group, is the 3rd thing in your packet behind the high-level work plan. So for today, we're going to first go through the QBR policy. That is a draft that needs to be finalized at the commission meeting in October. And we have Ed Baranek. Great, Ed. Welcome. This was first presented at the commission on September 10th, and will be presented in October as a final recommendation. We'll go through the details of that today and entertain any inputs and discussion or thoughts that folks have here so that we can continue to refine this recommendation so that it can be final in October. And then we're going to discuss just at a high level some the MHAC policy in terms of where what the overarching guiding principles are, and then what we've seen in terms of the MHAC policy results, and what might be in the cards for the updates going forward in the next year for fiscal 17 for the MHAC policy. We'll do the same for the readmissions policy. So we'll basically put the issues on the table that then will be explored in more depth in subsequent meetings of the work group, and then we'll adjourn. So turning then to the proposed work plan, again, we just went through today, and then in October 17, so about a month from now, we'll give an MHAC progress report. We'll also go into POA, that's present on admission. We have seen a drop in Maryland hospital-acquired conditions commensurate with December to January. And so our interest is to look at patient charts and coding of present on admission for accuracy with what is in the medical record, to get at any issues related to coding that may be there as opposed to actual drops in the Maryland hospital-acquired conditions. And then, so we'll explore that later. And then we are, for the readmissions, looking at a socio-demographic adjustment if we're ready and it's baked and it's possible. But that's going to be a very difficult feat. That we'll go into greater depth about that issue in October 17. Then about 3 weeks later, on November 5th, we'll have a draft MHAC policy, and then we'll do some modeling of readmissions with whatever components of any parts of the methodology that we want to add in for November 5th for readmissions. And then we'll have a draft policy for readmissions and a final for MHACs in November 21st meeting. And then you see interspersed there on the work plan are these hard stop deadlines where we have to present draft and final recommendations to the Commission when that is needed. And then in December 19th, happy holidays and come to a meeting here. And we'll look at the final readmissions. We'll look at potentially avoidable utilization measurements and some patient-centered performance measurement strategies. And we'll turn to our colleague Tom and Discern to help us with that, with some background work he's actually doing right now. So that will be very helpful then. And then, so we did put a meeting on January 6th on the books to finish up work that we may need to from what we are talking about in December, including the little bit longer term future plans of really getting at population-based measurement of improving health, reducing cost, and achieving the three-part aim. So that's the draft work plan. Is there any discussion anyone would want to have, or any questions at the moment that anyone would have about the work plan at the moment? Okay, so I think it's ambitious, but I think we're up for the task, and we're thinking about all these things right now, and we'll continue to have the wheels turn to get it done, and with the rich input and important perspectives of everyone in this group. So the other issues, we will have time at the end of the meeting for anyone who's come in the audience, and thank you for coming and being interested in this. If you have any comments, we'll save a few minutes at the end, so please know that your voice is important in this as well. Okay, so with that, I'll move on to the first. What we have as background material is the draft recommendation for the QBR program for fiscal 17. And if we recall, I'll show you the timelines. What we did was give you the draft recommendation document, and then I try to pull together these slides that concisely go over the details of that. So let's go through the recommendation. If you want to refer back to the draft, you certainly can do that, but I'll go through the slides in order to present the recommendation. So this is for rate year 17, which begins in July of 16, for which the performance year begins for some of the measures on October 1 of this year, October 14. So that's why one of our guiding principles is certainly that that we know how to measure this, and we know what the measures are ahead of time. So that's an important thing that we agreed to do early on in this process, probably 2 or 3, 4 years ago. So we want to honor that commitment and make sure that we are on track to know what we're proposing before the measurement period begins. So some of the other principle, well, the program itself, we were an early adopter. For those who don't know the history, CMS adopted their program and then began it in October of 13, and ours began in July of 10. So we were more than 4 years ahead, or more than 3 years ahead, I should say, of what was happening at the national level. Currently, we have 1% of revenue at risk. It was initially 0.5%, so we've progressively stepped that up. Just by way of comparison, the CMS value-based purchasing program does have 1 3/4% at risk, and will go up to 2% at risk in fiscal 17. So, and one of our requirements is that we need to be aware, align, and keep up with what's happening at the national level with the analogous programs that CMS has implemented, and that is the value-based purchasing program. Maryland was required under the old waiver to submit an exemption request, and we have a different taskmaster but same requirement now, which is that we still have to submit an exemption request, but that goes to the Centers for Medicare and Medicaid Innovation and is part of our contract under the new model, the new all-payer model. So we've spoken with them recently about what that entails, and they said it would probably be very similar to what pulled together and given to them in the past. So we don't see much of a change. It's just to whom we send the email with the documents to. Go ahead, Dr. Wynn.
Just for some perspective, so average hospital revenue, 2% of that is how much money, this ballpark?
Well, it's inpatient revenue. If it's a, you're asking me to do math.
No, somebody here knows the answer.
So, yeah, if you look in the last page,
Oh, right. Good.
the last page of the policy, we've actually modeled out results that we had from this year and changed it to 1.5 and 2%. So Southern Maryland, which had the lowest score, if you went across at 2% of their revenue, you can then see what the revenue neutral adjustment would be.
Okay, so what would it
for them at 2% would be like 156 million. Is that right? 150. Yeah.
No, that's
Impact.
that's their adjusted gross revenue.
Sorry.
3 million.
3 million. 3.1 million.
Okay, so $3 million.
I was like, oh my God, out of 156 million.
How much does an MRI scanner cost? That's $3 million.
That's, you raise a good point. That's the maximum exposure that the worst performing hospital under the QBR program would face. If modeling the data that we have right now, which is 2 years before it would actually be put in place.
Right. So the total for the entire state, if you use these results, would be about 10.3 million for the whole state.
Obviously, my question is that enough?
Well, we have other programs for which CMS's program for Medicare uses 2%, and we wanted to line our program up with what CMS was doing. We also have the readmission reduction program, which currently takes 0.5% of revenue, and we have the MHAC program, which maximum exposure is 4% if we don't meet a state goal, and 1% if we do meet a statewide goal, because we wanted to incentivize cooperation under that program. So all told, if you add 4 plus 1 plus 0.5, it's 5.5% revenue. Plus, there are other adjustments that are payment type adjustments. So it gets to a sizable amount. We wanted to spread it around to different incentive programs so that we're not putting all of the eggs in one basket, and that we want hospitals to pay attention on lots of different fronts where it's important and makes an impact in patient care.
I think the only other point that I would add to all that you said is that as part of the waiver contract, Maryland is to have our total amount at risk for quality programs equal to, commensurate with, what's at risk nationally. What I think we always have to remember is that in Maryland, that amount at risk is over our entire revenue base, whereas nationally, that amount at risk is over their Medicare revenue base. So it's a substantial amount more at risk in Maryland when you look over that total base.
Diane, could I comment on that? The question of adequacy of incentives in value-based payment programs is a fascinating one. It has as much to do with behavioral economics as it has to do with anything about health or health care. It's perhaps a topic we might want to explore at some point in the future, maybe with a national expert on the behavioral economics issue. But I think at core, it's really about is the incentive capturing the attention of the hospitals? And I think from various perspectives, you all could answer that. And on the other side of the coin, are we injecting undue risk beyond capturing the attention and getting focused on improving in areas? I would see those as two primary goals. You can have other goals for these programs, but it's a really intriguing question and one that I would suggest the group explore over time as we see the effects of the incentives as they go in place.
It's a very good point, and anecdotally, I can tell you that the quality team gets calls whenever this data goes out from case mix people, from finance people, from CFOs, from all the array of people at the hospital who are really want to dig into the data and seem to have a huge interest in it. And I get a bunch of them, and I know Elsa and Allison, probably Shule gets calls too. So I think we do have the attention, but it's not a formalized behavioral economic sort of analysis of that issue. But I think that's a very good point.
Good morning, everyone. Sorry, I was stuck in the traffic, but listening, in the listening mode. I would say also readmission penalties is kind of an interesting study to think about. The readmission penalty is very small. It started very small, and the reductions, the loss of revenue from the readmission reductions for the hospitals was much, much bigger, but hospitals still went ahead and reduced readmissions nationally. So, looking at the behavioral impact of the penalty seems like more than what the amount is, and more about public reporting, the impact of their in the scaling, where they stand. I think those are other additional impact of that scaling that has for the quality programs.
Since we're headed down this pathway, I'd just make one other point. The amount that needs to be at risk to get the attention depends on the business model of the entity as well. So, for example, in a physician's practice where there may not be so much focus on 1 or 2% at the margin, I can tell you, or I'm guessing, my experience has been that hospitals are very focused with what's happening with 1 to 2%. I see the financial guys nodding that, yeah, we watch these numbers very closely. So my sense is that we've got about the right balance here. I agree with Tracy's point about kind of tracking with the federal programs. We've been a little bit behind. But we also need to watch what happens over time with the incentives, and we don't want unintended effects. But we definitely want to push forward for the intended effects of these programs.
So now the slide about the guiding principles, slide 4. We wanted to address all patients regardless of payer, and you'll see that in the complement of measures, most of which are taken up wholesale from the CMS list of measures, but a couple are a little bit different, and it addresses this all-payer aspect, and we'll talk about that when we get to the measures. They have to be fair, and the hospitals have to be allowed to track, which also gets to the issue of knowing ahead of time what they are and what the benchmarks are. And then we should use benchmarks and thresholds where possible, or targets consistent with CMS's value-based purchasing program. And then we should emphasize outcomes as opposed to process. Going forward, increasingly emphasize outcomes. And that all hospitals have to participate in what CMS calls the OQR, Outpatient Quality Reporting, IQR, Inpatient Quality Reporting programs, and we must maintain our exemption by demonstrating equal or better performance with 2 CMMI, as I mentioned earlier. So we have we weight our measure categories for fiscal 16, which is what we're finishing the performance period in right now. We don't have an efficiency measurement because it's 3 days before and 30 days after, and it's Medicare patients. So it doesn't address right off the bat the all-payer issue. So we've reallocated the weighting for our measurement categories or domains across the other 3 domains. So the clinical process in our scheme and are 30% for Maryland for clinical process, 40% for patient experience, and 30% for outcomes. And for the QBR program, there happen to be 3 outcome categories or measures. Those are mortality, CLABSI, and PSI-90, which is a composite of 10 or 12 complications that occur in the hospital that AHRQ has put together, our Agency for Healthcare Research and Quality. And so each one of those are worth 10% to make up the 30% under that outcome domain. You'll know patient experience is higher, and one of the issues is we have a problem in Maryland where our patient experience survey results have consistently been lower compared to the national numbers. So we want to keep focus in that area. So in terms of how we're doing on these measures to the U.S. with the most recent data available, you'll see I put little symbols in there. We don't use the CMS heart failure, heart attack, and pneumonia 30-day mortality measure in our payment scheme for value-based, for QBR. CMS uses it in VBP, however, and we do better on that measure in the individual conditions and for the 3 conditions combined. That's why there's a little positive symbol, both in the base and the performance period. We use an all-cause inpatient mortality measure. We can't compare ourselves to the nation because there's no national measurement, but we can compare this measure with the nation. If you look across the clinical process measures, that domain, we're about equal. We're keeping pace with what is happening in the nation. And then for the HCAHPS measures, we don't do as well, as I said. So that's why there's a negative sign right there. And we've compiled that domain since they're measured. A higher number is better in that one. For the next category, which is called safety, which are outcomes, that's standard infection ratio, and a lower number is better. We only really have good data on CLABSI, and we do so well compared to the nation on the central line associated bloodstream infection. The catheter-associated UTI is a newer measure. Not all hospitals are in that measure right now. So I used caution in assuming we did worse, even though the ratio is higher than 1, which is not good compared to the nation. But again, there's not complete data on that one. So for CLABSI, we do much better than the nation with a good, solid data set and high level of participation of hospitals. And just to remind others, you guys, these are measures used by the National Health Safety Network, CDC, and our colleagues at the Maryland Healthcare Commission collect the data.
So when we measure these things against the entire country is huge. Is it easy to get a best practice score up there so we know what's the best? Who's the best state in each of these things? So we know it's attainable, and there's some.
I think that's a very good question, and I'm going to turn it to Teresa because to see what data you see as a user of the CDC NHSN data in terms of state by state. Can we look at the numbers by state? Can you turn your mic on?
CDC produces an annual report where they compare Maryland, well, all states. One of the issues is associated with the fact that what you alluded to about the collection of data in Maryland for CAUTI and some of the surgical site infections measures that were not collected in Maryland but are collected nationally. So for CLABSI, which is something that Maryland and all other states collect, we can compare ourselves to the nation, and we were higher than all other states in 2010, and now we're, I don't know if we're, well, we reduced it by over half, like 60% of CLABSIs, but I'm not sure where we stand with all states. But that's something we could get from that CDC annual report and actually provide to the group.
In other words, what's the best number that any state has gotten in these different measures? Not as not homogenized, but
well, it gives state by state.
Is New Jersey the best in this? What is that? Is California the best in this? What is that number? So you know it's attainable, and then it's something to shoot for. It's not just average. What's the best?
Right. We could do it for those using that CDC information. It can be done for those measures that you have here. Mm-hmm. And as you said, we won't be able to compare ourselves to those to other states for the measures we don't have yet.
Oh,
we
no,
can.
But, you know.
Yeah, that's a very good point. Thank you for that. And we can also do it with HCAHPS and, frankly, the other measures for which there's national data. We could look. CMS makes all of the data available in Excel and other formats, so we could pull that and look at it by state.
And also, if I could mention the new
Sorry, Tricia.
So the website that we're working on will give you state and national comparisons, and the top 10%. That metric will be there as well for the clinical measures and HCAHPS. So we'll have some.
When will that website be launched?
October. We're looking to present it to our commissioners in October.
This October?
Yeah.
Come up like next week?
Yeah.
2 weeks?
At the commission meeting, I'm sorry, not in 2 weeks.
Great.
Have you guys given any thought about breaking out some of these clinical measures by payer type? I mean, I think I would be curious to look to see how, Medicaid is doing versus Medicare, and, if we're really talking about all payer, all this money being at risk, what population is really being targeted within this program? So we no longer have patient-level statistics for clinical measures and HCAHPS, so there's really limited capacity for us to do analytics on that one. But for mortality measure, the things that we calculate, certainly we can break down by payer.
Right. So that's our PSI 90, and then 30-day. I'm sorry, the inpatient all-cause mortality for the top 80% of DRGs. What about the CLABSI and other NHSN measures? Is that available by? It's not identifiable by patient.
Well, we could compare it to the HSCRC file and then get the payer class from that. So one could do it by payer.
In the past, we couldn't match them. You didn't have.
Well, we've had more success more recently.
Yeah, we can. Matching the usual story.
Right. Well, that's a very interesting question because obviously you'd want to know that for Medicaid. You'd have an interest in that. Right. Okay. And certainly Medicare wants to know all things Medicare too. So, and okay. Great. Okay, so here in these next couple 3 slides, we're comparing what we're going to use for fiscal 17 with what's for QBR versus what's going to be used in the value-based purchasing program. So we'll start off with what is called the safety measures in the safety domain, and that's on the left column of the slide. Those include CAUTI, which is new for QBR but has been on VBP. The Clostridium difficile, this is new for VBP, but it will have to be added subsequent year, maybe for fiscal 18, depending on how much base year data is in, because we haven't been collecting it long enough yet for it to be used in fiscal 17. For methicillin-resistant Staphylococcus aureus measure, that is also new for VBP and has to be added a little bit later for QBR. And then surgical site infection, it is a new measure we'll bring on for QBR, and it has been a measure for VBP this past year. So we're continuing to sync up basically with what's happening at the national scene on these measures. If you go to the right column, you'll see the mortality measures that I mentioned, the 30-day condition specific. Those are VBP only because they are only Medicare patients. We use in all-cause inpatient 3M risk of mortality methodology, and that's for QBR only, and that is for all patients, and that's for mortality in the hospital. And then there are 3 process measures, and that's way whittled down. So the CMS focus on these process of care measures has really waned as we go forward, and to where we only have 2 immunization measures we'll use as well, that VBP and QBR will use. And then the PCO1 is an exciting new measure that has been used at the Maryland Patient Safety Center for the perinatal collaborative, but the data is not made public. It is going to be new for VBP going forward, but not ready for prime time for fiscal 17 because the data won't have been in the CMS warehouse long enough. Hospitals report it, but it's private, And we hear from the Safety Center that 39-week early elective delivery has gone way, way, way down. It's very, very rare that those deliveries happen. But we will, again, adopt it if it's still in the mix when we are ready to adopt it and there's enough data. For the other domains, VBP and QBR will, again, use all of the HCAP subdomains. We do very well on the discharge information question, on par with what's happening at the national level. And we do believe that's because we've ramped up focus and set up incentives for care coordination and care transition and readmission reduction. So it's interesting that that one measure is the one that we do see on par performance with the national results, but the others we do not. We're below. And then, again, for efficiency, Medicare spending per beneficiary, that's Medicare only, and we need to develop on a parallel track an efficiency measurement that is currently the background work is being done. So here's my timeline slides that has that shows you base period and performance period for fiscal 17 and when the impact hits. So that's why we're doing this early planning. There are slightly different time tracks for instance, readmissions and mortality than there is for the QBR and HCAPs, for base period and performance period. And also the MHAC program, we threw that in there just to show you that, since we're going to talk about that a little later, that's also on track with readmissions and part of QBR. So 3 of them are on a similar track time-wise, and then the HCAPs and QBR core measures are on a quarter earlier just because of data availability.
So in general, if the measure is calculated using our data sources, we use the fiscal year as the base and the calendar year as the performance, and there's that 6-month gap between base year and the performance year to accommodate the timelines of the data submissions. So then the only difference then is the measures that we get from CMS or other resources, the time lags are much wider. It's not only 2 quarters, 3 quarters between the base and the performance.
Diane, the MRSA bacteremia is January 14. That's what you have July 13.
Okay. MRSA is January of 14?
Yep.
And that was on the other chart?
Yes.
Yeah. Okay. Is CDIP correct?
Yes.
Okay.
The others are correct.
Okay, great. Thank you for pointing that out. Okay.
I apologize. Everybody else probably knows the answer to this.
Yeah.
The survey, is the same surveys given across the whole country?
HCAP? Yes.
It's administered by the same people?
Hospitals can use vendors. The administration specifications have to be consistent with the federal specs, and I would say it's a highly reliable, valid survey in terms of the delivery implementation method and the results.
Is it given 30 days after discharge? I have no idea.
I think I should know this answer. It has to be given within 30 or 45 days after discharge. And there have to be a minimum of 100 surveys.
Yeah, and there is a sampling too. They are not giving it to all patients, so that there needs to be, if it's a big, hospital, they do sampling of discharges.
300 cases they have to sample.
Right, and it's divided out by medical, surgical, and OB patients. And they're adjusted separately for those patient populations. Okay, so in terms of how the weighting will occur for 17, here's where the technical recommendation to the commission will need to go through a final approval at the October meeting. It's on 2 issues. One is the weighting of the domains, and the other is the revenue magnitude at risk. So here's one of those. The clinical outcomes you'll see for CMS VBP, the outcomes, they're weighting at 25%, and the process measures, those 3 measures, immunization 1 and 2, and the 39-week early delivery, those are 5% of the equation. For patient experience, they're weighting at 25%. Patient safety, those are all of those infection measures, if you recall, are 20%, and then efficiency is 25%. So if we go down to the bottom row, for Maryland, what we're proposing is that we do 15% for outcomes, and that is only the mortality measure, the inpatient mortality measure. Last year, that inpatient mortality was 10%, and we are proposing bumping it to 15%. We had it higher in an earlier draft, and we got an early recommendation that we thought was reasonable to ratchet that up more slowly. And then we want to comport with the VBP program on the percentage for the process measures and leave that at 5%. And then patient experience was 40. We want to bump it to 45 for the reasons that we've discussed already. And then we are weighting more heavily these patient safety measures that include the infections, and I'm sorry, they also include PSI 90. And then we're absent the efficiency domain, so we've spread that efficiency amount across the other 3 domains. So I'm going to pause here to see if we have any questions or discussion about this.
I'll just say I'm not recommending any changes. Just as we've discussed this, this is a hard, getting these domain weights in an equitable way is difficult to do. And what we've wrestled with is that mortality measure. Because we only have the capability to do the in-hospital mortality, we wish that we could do a 30-day mortality, because large percentage of the deaths happen in the 0 and 1 day stays, and they tend to be clustered. And the results can be variable. So recognizing the limitations of the methodology that we have, and frankly, there's no other suggestion for how to do it, a different measure to use. It's really difficult, so we're a little uncomfortable with going any faster there. We can't, the process measures, those are not that critical, so it's hard to put any more there. And without a separate efficiency measure, we don't have weighting to put there, although you could say that the whole waiver is an efficiency incentive. So we don't have too much left here. So I think it's difficult, and particularly to say 45% on the patient experience of care is hard to stomach. But I think that we've got the balance, as uncomfortable as we are, that's the best way that it could be balanced.
Yeah, so my questions were all about mortality too. So I don't understand it well enough. Is it all patients? Is it just patients with diseases?
So how the measure works is it takes the DRGs that constitute the top 80% of death in patient before the patient is discharged. So it's a much broader measure than what the CMS methodology uses. It's based on HSCRC case mix data, so it's when the discharge disposition is death, and we measure it for every patient that goes into the hospitals in the denominator. The CMS measure uses claims data that's matched for the patient conditions of heart failure, heart attack, and pneumonia with death records through the Social Security Administration. We have explored ways to link our data with vital statistics, but we have run up against them.
Didn't we get good news from ARC that the Agency for Healthcare Quality, I think, is approaching states who are interested in linking with vital statistics. So we are exploring that avenue to get the 30-day mortality.
Right. I said on that call, and it was sort of a circuitous thing where if we don't have a unique ID that matches with vital statistics, it's not going to be.
Me too. Before you get, I mean, does this include patients with cancer?
If they're in the top 80% of, except, what do we do with the hospice? And
they're excluded.
Right, we exclude hospice. Right, so we do exclude hospice and rehab. Turn your mic up.
You exclude hospice, but so what does that mean exactly? You don't exclude patients with cancer just if they're in a hospice program.
You exclude cancer patients. I mean, they're a whole list, right? Cancer patients.
In general, we looked at the DRGs, and if it is a high DRG mortality and there is not much variation, I think cardiac arrest was one of them. We excluded those. So we're looking at the high mortality DRGs, which there is a variation. And on the specific case basis, we have indicators for hospice patients in the data set, so they are excluded totally from, regardless of the DRG that they have, hospice and palliative care patients are excluded. And then on the adjustments, we have adjustments for transfers. If the patient is a transfer from an acute hospital, so basically the risk adjustment controls for it. We don't exclude them, they are adjusted. And then we adjust for age, and I think that's about it, if I remember correctly. We can send you
the methodology.
There is a good documentation if you're interested with more detail. So it's a very different measure than the CMS measure, but the 3M risk of mortality indicators, which are similar to severity of illness, are supposed to control for the inpatient mortality risk already. So even though it is limited, not including 30 days, 3M methodology is developed for inpatient mortality risk. So I think in that sense, the measure is not, it is usable. It is a validated measure.
It's tough. It's a tough thing to measure. So what you're saying is you're able to adjust for the difference between a 25-year-old that has a pulmonary embolus that doesn't get diagnosed and dies in 2 days versus somebody who's 80, has multiple conditions.
Yes.
And, you know,
yes. They're not all in the same bucket, if you will. There's just, exactly.
Right. And again, we compared the expected from the 3M to the observed. Is that the risk adjustment? Right. Yeah.
Okay. I mean, do the hospitals think it's a fair measure? I mean, do the doctors and the QI departments of the hospitals think it's really meaningful?
I think conceptually we agree with the approach, and we were certainly included in the development of that. As we look at the data and see where some of these are clustered, I think there's discomfort with that. But I think we're very limited by not being able to go beyond just the inpatient stay. I mean, recognizing that the product is, as Shule said, has the risk of mortality baked into that. Still, I think we could say that in using 3M's other products, like the MHACs, now it's been 4 years, 5 years, that it's taken that long to really dig into those definitions, get used to working with the data, and that's when the questions surface about, well, you know, we need a better guidelines on how we document this or that feeds into what the outcome is. So this is starting on the second year. I think it's the second of using the mortality metric. We see some things that we would like to dig into further, and we can only progress so quickly. So it's not perfect, but it's usable.
So by focusing on that top 8 DRGs, we try to eliminate the variation from, you know, one case that in a, you know, very small cell size. So that's, we try to get that measure more on the aggregate level. Not only, but another limitation that I was hoping we could address is nursing home patients. We see a high risk of mortality for patients coming from nursing homes, controlling for everything else. But looking at the data, admission source is so bad in our data. Some hospitals have 0 patients coming from nursing homes. We couldn't put an adjustment for it, and we've been working with the industry to improve that coding so we can control for the nursing home patients.
They all end up coming through the ER. If the nursing home patient's taken to the ER, that's the admission source. And we're trying to get hospitals to do a better job about that, but
let me ask it a different way. People have one of the most common procedures, elective joint replacement. So people who die after an elective joint replacement, is that reflected in the safety part, or is it reflected in the mortality part, or in the process part?
If they had a complication like a fat embolism and a PE, they get a Maryland hospital-acquired condition or a MHAC, and if they die, they're measured there as well.
And they are in the mortality measure.
They are.
So you measured more than one place?
Yes.
I think that the mortality metric is really dominated by people who die from sepsis in 0 or 1 day. So that it was a huge proportion. That I want to say like 78, 75. I mean, it's a big amount. So I'm sure that's driving those results there. Although I guess a joint death after a joint replacement would be in there too, but I would think it would be small.
Anything on the webinar, Jess? Okay, thank you. So we did talk about already that CMS is ramping up to 2% for 17, and we modeled the 1.5 to 2, which Allison's already gone through and Dr. Wynn already asked about. So you are forward thinking. Thank you. And again, there's a 7.7 versus $10.3 million redistribute under the scaling if you use 1.5 versus 2%, and that's on the last page of the recommendation document itself.
So I have a comment here, and that is I recognize the need to be kind of on par with the nation, knowing that our programs in total need to match up with the national amounts at risk. How will we decide how much is at risk for the other programs, readmissions, MHAC, anything else that might come along for this year? What I'm a little uncomfortable with is setting this at 2% and feeling locked into that couldn't be adjusted as we then look at the other programs. If there would be a way to look at those in total.
Yeah, the timing-wise, unfortunately, I wish we could do all together. QBR had to be done early, and jumping from 1% to 2%, we felt that that's probably what we can achieve in 1 year. And the aggregate amount at risk, we've been talking with CMS. We had intense discussions in June about how we would think that it shouldn't be that complicated, but somehow everyone understands differently what aggregate amount at risk is. Is it the actual penalty? Is it and then the base? I think the major issue is about the base. We had that discussion. Theirs is on the Medicare, and ours is on the all-payer. Apart from that, theirs is also on the base payment, whereas ours has all of it. So we are still talking with them, and hopefully by the time it's time to decide on the MHAC and readmission, which are going to be done simultaneously, we will have a better, we would settle on what those aggregate amount at risks are. And also, even though we don't have efficiency in the QBR, we do have an efficiency adjustment in the demographic adjustment on the GBR, global budget revenues. So that's part of the calculation, and CMS is trying to understand our concept of efficiency and how it dovetails to other R programs. To us, I think we feel comfortable locking in to 2% in QBR, and then hopefully we would have enough flexibility for the impact and readmission to achieve the aggregate amounts.
Okay. The other thing that we've talked about, and I know we've talked about this, I think, offline before, and that is the QBR, how the adjustments work is by scaling. And with the data coming from CMS and the different domains coming together, hospitals may be able to have an indication of where their performance is, but they don't know their performance relative to others. So as we increase the amount at risk for QBR, I think it's important that they could have, say, some interim results throughout the year. And I know there's challenges with, since we're not calculating the core metrics and some of these other metrics anymore, we're relying on CMS's time frames, and it's not perfect. But I wonder if we could have just a small group, maybe Teresa and someone from HSCRC and a couple hospital people who are these metric gurus get together offline and come up with something. It won't be perfect. It won't be as good as the PPC and readmission data that we're getting now, but it would be something to help them through the year.
We do have the QMDC at part of our new website where hospitals submit data, and that's where we want to post information like that would be useful to hospitals. So I think a small group could get together, find out what hospitals can use on an interim basis, and then post it there.
Yeah.
Great.
Yep. That would be terrific.
Okay, so we'll put that on our to-do list to get a subgroup and ask for a couple recommendations.
Yeah. Thanks.
So we had the discussion along the way, and we appreciate people being attentive and thoughtful about their comments. And if other things occur, we do have a deadline of input by Monday for the draft recommendation, and then and those should be sent to me at my email address, or you can put them in snail mail or however you want. So if there's no more comments about QBR, I'm going to go ahead and ask Allison to move forward with the MHAC discussion.
Good morning. What we're going to do today is just very kind of at a high level go through what are some potential updates to the MHAC program that we might want to implement for rate year 17. We're going to give a brief summary of, the program overview, the guiding principles for developing the policy, the results that we've had this year under the current program, and then again what would be some potential updates and what would be the next steps we would need to do to be able to get the information we need to make these decisions to come up with a draft policy and a final policy to go to the commission. Many of you have been involved in this for a long time, so you know that our MHAC program is based upon the list of 65 potentially preventable complications that was developed by 3M. These complications are generally harmful events that occur as a process of care rather than the natural progression of disease. And they rely on the present on admission indicators that are in our case mix data. And the program tries to link hospital payments to performance by comparing the observed number of PPCs to the expected number for each hospital. So these are the guiding principles. Again, our goal is to achieve the 30% reduction that's required of us by CMMI for our new waiver contract. We have to have also all of our programs meet or exceed the national programs in terms of the measures and revenue at risk. We have this program as all payer. we have worked to prioritize high volume, high cost PPCs, or ones that have an opportunity for improvement or an area of national focus. We also want to be able to have predetermined performance targets and financial impacts for the hospitals. We want to encourage cooperation and sharing of best practices and hold harmless for lack of improvement if attainment is highly favorable, and provide hospitals with the ability to track progress. None of these have really changed since we developed last year's program, where we did things like took away the relative rankings and instead just have a preset scale that people can use to determine if my score is this is the percent of revenue I'm at risk to losing, as well as implementing both an attainment and an improvement program where it's the best of. Again, so this goes through the methodology. We changed from looking at the excess cost of PPCs last year to looking at the observed to expected ratio. We then tiered the PPCs into 3 tiers and weighted more heavily the high cost, high prevalence PPCs, as I mentioned. We do APR, DRG, severity of illness adjustments, and we also did some limited case adjustments as well as small cell size exclusions. So if you have less than 10 patients at risk for a PPC, that PPC is removed for that hospital, or if you have less than 1 expected. Again, it's better of attainment or improvement. We set the threshold as the state average, and we set the benchmark as the ratio of the cases from the top 25% of hospitals. We also had 5 serious reportable events where the expectation was 0 for those 5. The scaling, again, is point-based, preset, and it's not, it may not be revenue neutral. The statewide performance impacts the scaling results as well. So we set a minimum improvement target of 8% for the state as a whole, and if we achieved that, the maximum amount at risk went from 4% to 1%. Hitting the laser pointer into the audience rather than forwarding my slides. I apologize. So this graph is presented at the last commission meeting showing the risk-adjusted PPC rates year-to-date for calendar year 13 through July of 2014. And if you look at just the box here, essentially the risk-adjusted PPC rate from all payers in July of 2013 was 1.3, and it has dropped to 99. And that is a almost 24% reduction in PPCs, and as you can see, most of that reduction just occurred from December to January. So as we mentioned, we do audit. We've audited since the start of the program, I believe, hospitals annually. We audit a certain number of hospitals to look at their coding, and we're currently looking at, developing the criteria for choosing what hospitals we're going to audit this year and whether or not we need to change any of our auditing procedures to sort of look at this issue. There may be very valid improvements in coding that are part of this. We want to make sure that that is the case, but we also want to be able to talk to CMMI about what percentage of this is really attributable to improvements in quality of care and what percent might just be valid improvements in coding.
So this kind of presents a challenge to us. If you remember, our 5-year goal was 30%. One question is how much of it is real. Even if it's data, basically the historical data was bad. That you can explain. But then I think we would need to discuss with CMMI then how we could adjust the 30% reduction. Obviously, 30% reduction was meant to be the real improvement in care rather than the coding improvements that we think we are seeing in 1 month.
Okay, so you thought about this a lot. So even with, why do you think there's a 17% reduction again?
Right now, we are puzzled. It's not a single hospital. You're going to see the hospital table. There is not an outlier hospital that we are going to this hospital improved. There is not a single PPC, so it seems like over the board. The other thing that is kind of puzzling to me, in January we went to a monthly submission timelines. Before they were doing quarterly. We are also thinking, looking at just the number of ICD-9 codes that they are reporting, maybe there is something going on there too. So it's still, we're exploring, and we think that the auditing and talking to hospitals who are at the high end of improvement may help us understanding why there is such a big drop.
Yeah, and just to piggyback on that, so again, they're submitting data monthly and then data, quarterly final data. We do see improvement, between the preliminary and the final submission, and I think the hospitals have a lot more time to look at the case level details of the cases. So it's not always just in the preliminary data that we see the drop.
This is Beverly Collins. Also, I have a question about that. The Medicare fee-for-service, is that only from Maryland hospitals, or are those national? Because it looks like it's something going on all over, or if it's just a Maryland-specific.
That's just Maryland-specific hospital.
Okay.
Out of the 65 complications, do they all depend on a POA? Whatever,
yes.
Information, flag, whatever. Does that work well?
Maryland has been coding present on admission since 2006, I think, or before. And 3M and Michael Pine in Chicago compared our present on admission indicators in terms of the validity with using yeses, nos, unknowns, codes that should be exempt that are on the quote exempt list, and there's a it's not known or it's not documented. There are a U and a W. Anyway, those indicators seem very reliable in terms of the corridors for which one might see for the yeses and the nos, et cetera. And also for those conditions you would expect to be chronic, they're coded as yes in general. So hospitals are very good at coding POA in Maryland. There's also a depth of coding to the 29th secondary diagnosis that is well beyond what CMS sees in the Medicare claims and what's done in other states. And we think it's because we've been using it for payment for the last several years. Now, that being said, though, we do have some screens, and an example might be a patient who goes into the hospital who has an extended length of stay for a condition, for the relative condition for which they went in compared to that same AP or DRG category and severity level, but there's no complication coded. That Michael Pine has helped us develop screens like that, and we've been able. It's the most difficult auditing to do, which is what can you find out that you don't know? Which is it wasn't coded, and how do you find the cases that weren't coded? That's a very difficult proposition than getting the cases that are coded and working with those. So we're going to work out some criteria along those lines and along the lines of the case level findings that we have to try and kind of suss out some of that, and then work with our auditors. We use Optum, and they'll go in and pull charts and help us look through that issue, because it seems like this finding definitely warrants that level of scrutiny.
Yeah, I wondered. I mean, yeah. I wonder whether there was new software that was handling the POA situation differently, and maybe that was the issue. I don't know.
I think one of the other concerns that we have is also whether or not the coding that goes on the actual claims that goes to CMS are consistent with what we're getting as well. Because if they run their own analysis on those claims, we want to be able to see similar results.
Right. So historically, Maryland didn't have to submit POA to Medicare until October of 13. And that means they couldn't calculate their own version of, let's say, PSI 90, which also relies on the POA being correct. If you look on Hospital Compare, there isn't data for Maryland on that measure because POA was not at all consistent. So we're trying to get the ducks in a row with that as well.
And the MedPAR data is limited to 9 codes versus what we got to 30 now.
Right.
So that's also a big difference. And most Maryland hospitals drop a Medicare claim and never rebill after cleanup on data.
Yeah.
So that also presents another issue.
Yeah, I think that's going to create a major challenge to us because CMMI is planning to look at the PPC rates in Maryland compared to the national estimate, and if our hospitals are not correcting their POAs on the claim, you are not going to see the true PPC rate there. Do you know nationally what they do, like other states?
Nationally, they resubmit claims, but it's never affected our payment because we don't get paid on a DRG basis. So, and the changes don't affect the charges. It's just the coding related changes, which, as you all know, we work on until final submission of our data. So it's a two-part issue. One is the limitation on the number of diagnosis and procedure codes in the Medicare records versus the HSCRC records. The second is the refinement of the data. The HSCRC data is much more refined than what's dropped on a Medicare bill.
We may need another subgroup for that, but nationally there is an incremental DRG adjustment for certain complications too. So I think all other hospitals in the nation were paying particular attention, and then the HAC national program came in. Even though we don't have a direct adjustment, CMMI is going to compare the Medicare numbers using their own data, and I think if we don't find a way to send them the correct data, we will be in trouble.
Well, and bigger than that, though, the Medicare claims are what they're going to use when they compare what we're saving, how we're performing, and it's not going to comport with case mix data.
Well, the dollars will.
The other metrics.
It's the metrics that are driven off the diagnosis code, but some of that, even if we did get it 100% accurate, it's still going to be different because of the limitation of 9 versus 30.
Right. We are going to, that to us, they understand that, and we are looking at the impact. I think they may have a contractor to look at it. But what we are concerned is with the 9 that you're submitting to make sure the POA code is correct for the first 9 that you're submitting. And then the issue of the other hospitals, the sequencing, impacts the DRG, and Maryland hospitals do the sequencing for the APR DRG, not Medicare DRG. So some of those high-weight ICD-9 codes may not appear in the Medicare claims either, which is another, once we get the data, we are planning to look at the DRGs as well to see how much of impact that one has. The only question I have, I don't understand the billing, but have we tracked this against all inpatient admissions and discharges? Are you seeing a decrease overall as a percent of people coming into the hospital? It's relatively the same.
Are you talking about payer or?
I'm talking about overall. So if admissions or discharges are going on, you're not going to have these complications because it's.
I think then your expected rate would be lower because your at-risk population would be lower. Okay. So I think it is accounting for that. Yep. And just to move on real quick, we also we do have a handout here to look at, but this is also just a quick graph of the percent improvement by hospital. This hospital over here with 100% had 1 expected and 0 PPCs, so They've had 100% improvement in their PPC rate.
So that's our McCready, who is, always creating a challenge for the data.
Right. So as you can see, lots of hospitals have gone down. There's also been a handful that have had increases in their PPC rate. Although, just as with the reductions between preliminary and final, we've seen those drop almost by half when you go from preliminary to final. So they are also, looking at the coding between those data submissions and working on that. So then if we could just take a look at, there are two, they're the sort of legal size handouts. So if you look, and Jess, I don't know if you're going to put them on the screen or you don't have them, but it doesn't matter. If you look first at the first one that kind of has the multiple colors across the top, this is the final scores by hospital. This is just showing you, the hospital, the number of PPCs that were included, and then for each tier, what are the number of points and possible points that they scored. And then if you go all the way over, then you end up with the final weighted score. And this table is sorted from low to high. So you can see that currently, year to date, the final scores go from 0.37 up to 1, which is that lovely McCready.
So this is data through June?
Through July.
July?
Mm-hmm.
And up to June is the final data, correct?
Correct. July would be preliminary data, which is, if you go back, I think, to the graph, which I can't do right now, you see a little uptick in July compared to June, and that's probably because it's preliminary. So again, one of the reasons this is important to look at is when we get to talking to the next steps. If you'll recall, last year what we did was we took the base year scores in that range, and that's what we used to set our preset scale, where the lowest score was this and the highest score was this. So last year I think it was about 0.17 to 0.8 something was the range. This year, the scores would be much, much higher. So I'm sorry. Then the second handout is then just looking at the improvement by hospital. Again, it's sorted by their improvement rate. That's on the far right. But it shows you the observed to expected year-to-date for 2013 compared to year-to-date for 2014. And we can look at these again when we're going through sort of the next steps if there are questions. But. Okay. So going back really quickly to our presentation, thank you, Jess, for your trying to keep up. So now, talking about rate year 2017, unlike this year where the base year was calendar year 13, we're moving back to where it is the fiscal year before that we look at for the base period. So that would be fiscal year 2014, and then the performance period would be calendar year 2015, again then to impact rates starting in rate year 17, fiscal year 17. So these are some of the considerations that we as a group are going to need to look at. So first, our basic approach around the MHAC programs is that we want to keep the changes to the minimum necessary. We did a lot of changes last year, and I think we need time for people to absorb those changes rather than making major changes this year. We're going to need to determine what a statewide minimum improvement target would be. We need to examine what would be the maximum amount at risk, whether we continue with having 2 scales and what are the differences with those scales, how we set those scales, again, using the base year information, what is the range, and is that the right approach. The other potential changes is we can look at the tiering of the PPCs to make sure that we have the right PPCs, especially in Tier 1. We can look at the serious reportable events. We also have been having some discussions with 3M, and they've started to look at the sort of case level and small hospital exclusions. So is less than 1 expected and less than 10 at risk the right number? And also, sort of looking at that small hospital issue, why small hospitals do seem to do generally better. on some of the PPCs. And then also we did meet with a clinical group. 3M joined us to discuss the clinical definitions for the PPCs, and some of the feedback that 3M received has been implemented into version 32, which will come out in October this fall. And we just want to add that if there are any additional clinical recommendations or concerns that hospitals and clinicians are having, that we would need to get those soon so we can look at them as well as decide if we need to make any changes. So I'll stay on this slide, but open it up for any questions or comments. Again, if you go back to the work group proposed work plan, at the next meeting we'll sort of give you an update of where we are. We'll probably present some of the findings around the small hospital exclusions and looking at what would be the scale if we use fiscal year 2014 as the base period, so that we can discuss that more further. Okay. So if there's any comments from my colleagues, or should I move on to readmissions?
I think I answered my own question, but looking at, as we make the updates to the MHAC policy, I agree with and understand the what we'll be looking at. What's in my head is, as the with this good performance in fiscal 14, those become the new thresholds and benchmarks. Then you have the high scores in this performance period, and if we set the scale with those high scores, I think it would be, I can't predict in my head yet where that's going to land us, but I hope we get to see those as we go through this.
Yeah, so those are the things that we'll prepare for the next meeting,
okay,
so that we can have the discussion about them.
Okay, and yeah, that's what I was.
Yeah, and I think for this year we may do, we need to find a way to take into account this big drop. You know, you don't want to keep the, if this is data cleaning, let's say, if you do a fiscal year, base year, you know, you don't want to keep this old data in there. So there's going to be some adjustments we need to think about how we handle the big drop.
Yeah, that makes sense.
All right, so next we're just going to, again, walk through at a high level potential updates for rate year 2017 for the readmission reduction incentive program. We're going to go through, again, the overview of the program that we have currently, the guiding principles, a brief summary of what are the results year to date, and then the potential updates and next steps. So as you guys know, you helped us implement a new program, the Readmissions Reduction Incentive Program. This was done in part because Maryland's readmission rates are high compared to the nation, and because of that, we have the goal in the CMMI contract of needing to have the Medicare fee-for-service readmission rates be at or below the national rates by 2018. So we set up the program to be so that in rate year 2015, any hospital that meets or exceeds a 6.76% improvement in their readmissions from risk-adjusted readmission rate from calendar year 2013 to calendar year 2014 would be eligible for up to a 0.5% bonus in their rates for rate year 2015, provided that there was a update factor that's variable. I think that S needs to say rate year 2016. I apologize. We're currently in rate year 2015.
Allison, does 6% mean going from a 20% to a 14%?
No, it's the it's not percentage point. It's a percent reduction. So
really could be like a 1%.
Mm-hmm.
I mean, a 1 percentile.
Right. Yep.
That's not very much.
I mean, I think if you look at, and maybe other people could talk about national trends and reductions, I mean, I think we tried to model out where we expected Medicare to be 1 year, and we tried multiple years, and we looked at what we expected the reduction to be, what we expected the difference between the nation and Maryland to be, and we used all of that to sort of develop that 6.76% as the minimum needed.
Well, not very much.
But as an absolute, our position relative to the nation is, what, a 2% spread?
Mm-hmm. About, yeah.
Yeah. So if the nation's at, what, please correct me, 16% and we're 18?
Yep.
That's about the
About
relative
right.
magnitude. So we've got to get, assuming that the nation improves,
Mm-hmm.
so by the end of the 5-year period, assume the nation's at, I don't know, 15%. So what do we need to improve by? You could do it in the absolute numbers, but
right.
It would still be the same relative change year to year.
Yeah, but the guess is what the rest of the country is going to do. So what if the rest of the country improves by 4 percentile points? I think this is moving more quickly than some people may have
Yeah,
thought.
I mean, this is a moving target, and we need to take those improvements into account.
Mm-hmm. Was the magnitude that we estimated for the national improvement, that was around 5%?
Mm-hmm.
We estimated the nation would improve in 1 year, and then to close the gap that existed where we thought the base period was the additional 1.76. So that was kind of how we came up with it. But like Ed said, those are percentages of improvement, but you could do that same calculation on percentage points.
Yeah, we did present both last year, and I remember the discussion. They didn't really matter too much. It's just a matter of how you understand the numbers. And I think we end up using the percent, but if you're more comfortable, we can always add the percentage points there.
Maybe I'm not articulating this very well. If the rest of the country is improving more quickly,
right,
then that number won't accomplish your goal. That's what I was trying
Right.
to say.
So we would have to increase that number. Absolutely.
Yep.
And actually, just to, in the qualitative sense, a 6.76% improvement is no small feat. It's tough to move those numbers, and it's not an easy goal.
Sorry, I thought the next slide was the graph. So well, and we'll show you the results thus far. Again, in the current program, wrong rate year, I apologize, we have the risk-adjusted readmission rate. It's 30-day, all-payer, all-cause, all hospitals, so both inter and intra-hospital. We do some exclusions. We take out planned readmissions using the CMS planned admission logic, as well as making sure all deliveries are marked as planned. If somebody dies, they aren't eligible for a subsequent readmission, although if that hospitalization is a readmission from a previous one, that would get counted. Same-day transfers are combined so that they only count once in the denominator, and they count from the hospital, the second hospital that that the patient is discharged home from, and then rehabilitation hospitals are excluded.
Behavioral health, psychosis, substance abuse, are they in?
They are in if they're in for the acute hospitals, yes.
But not in, let's say, Shepherd Pratt's not included.
Right.
And I think that's a good point, too, because when we compare the readmission rate nationally, they calculate that on the PPS hospitals, which excludes a lot of psychiatric. So in Maryland, the only psych cases that are excluded are those that are at the specialty hospitals. So all of the psychiatric cases that are in what look like a distinct unit but are actually on paper acute care hospitals, those are included. So I would say that the Maryland numbers have a higher percentage of behavioral health cases in these numbers, and we know that that's definitely a risk factor for readmission.
So so this is, again, the same graph, but for risk-adjusted readmission rate year-to-date. And so this is only data through June because we need July data for the readmissions. So it's discharges through June. So in June 2013, year-to-date, the all-payer risk-adjusted readmission rate was 12.4. It is now down to 12.1 in calendar year 14, which is less than a 3% reduction. This next slide just shows you, again, the variation across the hospitals. So as you can see, there's, I think, about a dozen hospitals that are on track for hitting that 6.76% reduction. And then there are hospitals that have improved, as well as hospitals that have had an increase in their rates. We have provided a handout. It's not on legal size, but it's this sheet here that that shows you the results by hospital, sorted from best improvement to lowest improvement. So for rate year 2017, the base period will be fiscal year 2014, and the performance period will be calendar year 2015. The considerations that we need to decide on as a group will be what the statewide and hospital-specific targets. So in this first year, we set a uniform target for all hospitals, but we may want to include, we may want to do a couple of things. One, we want to account kind of cumulatively over time for the hospitals that did very well in this first year, because they may not have the same ability to improve in subsequent years, as well as potentially set different targets based upon sort of where you're starting out. We need to think about the payment incentive structure and what the amount will be. Again, it's 0.5% as an incentive with no penalty other than not receiving the incentive. And it is we've done some exclusions and adjustments. So we have we will implement the latest version of the CMS planned admission algorithm, which has a few changes to it. We also are looking at whether we should exclude multiple births. And then we need to consider whether or not we need, we are only risk adjusting currently on the APR-DRG severity of illness. And with proper adjustments, we might be able to actually have improvement and attainment. But the two issues that we need to sort out, one is out-of-state readmissions, and two is risk adjustment for other factors like sociodemographic variables, or even adding things like age or some of the other variables we may have already in our case mix. So I'm going to, again, leave it on this slide and open it up for some questions. Are there questions or concerns or things that we may have missed that we will need to address in this next year?
Maybe then I'll give you an update on the Medicare numbers. We don't, ninth month, right? We don't know. So CMS is going through a revision of their algorithm, and they told us, verbally that we are doing good. So they said nothing to worry about, but we weren't able to get the numbers and validate them. So hopefully we will have speed up process, so by the next meeting we have a better understanding of what our base number is for the readmission and how far, what we did in the whatever the numbers that they can calculate for the first 8 months. I would say, Dr. Vin's point, we really need to find a way to see what the national trend is and attach our program to that. And we predicted 5% when we'll see what the national trend is with that. And I think the new, the Virginia what QIO?
The Virginia Health Quality Center, but they go BHCQ.
So, you know, some of you know already, so Delmarva Foundation is no longer our QIO. We have a new QIO, and in their contract, CMMI told us that there is a specific clause for them to look for programs that will be applicable for all payer model. So we are going to work with them closely, and I would think that readmission, we're going to continue working with them to understand why we are high and what explains the trends between the national and the Maryland differences.
So again, it'll be interesting to know what's the best attainable, you know, not just like all this homogenized stuff, but, you know.
Can I just complain a second? We asked for a state-specific data from CMS, and they told us, why do you need all the states? Benchmarking.
Right. I do have a state comparison that I got from the Colorado QIO about 9 months ago that I can share with the group.
The problem is you want to put it on the measure that you are measuring. So
right,
you know,
it's a slightly different method, but it's the only comparison we have that we've ever been able to get from anyone, which is, yeah.
I mean, it would be wonderful if somebody who's really smart could figure out a sophisticated way to risk adjust for socioeconomic or demographic. Obviously, that's a big deal to do with it.
I guess the Congress, would you count them as, I think there was a bill going through for the readmission adjustment for socioeconomic factors. But yeah, we are approaching a couple statisticians and researchers who can help us think about this. And hopefully, you know, as we work more, we will bring you some substantial methodologies. Ultimately, I guess if NQF can validate one measure, right, that will be
Good start.
Yeah. Okay. All right.
That concludes our agenda.
I'm going to ask if anyone on the phone, any hand raising, or whether anyone who's taken the time in the audience to come and listen has anything that they would like to say. Okay, all right, great.
Thank you.
Oh, wow. Great.
Always nice to get out early.
Yeah. Yeah. Was it good?
Yeah, all the measurements.